Thank you. Good morning. It's my turn to thanks very much George and Antonio for their kind invitation to come again here in Athens. It's always a huge pleasure to be here and to share with you both science, medicine, but also history, wine, good food, and so on. So, So my task today is to talk a little bit about fluid therapy and sepsis. So first message is there can't be one single type of fluid to take care of all clinical conditions, simply because depending on what the patient has lost, the composition or the content of the fluid to be given to the patients would be different. That said, I will like to go through the benefit to risk ratio of colloids versus crystalloids in patients with severe sepsis and septic shock. So, to begin with, you all remember this story about the albumin coming 15 years ago when after a Cochrane review suggesting harm from albumin, lay people and lay media rose concerned about medical malpractice exposing patients to harm and death. And this is important to highlight right now just because we know today that this is wrong. So we need to be very careful in drawing conclusion even from Cochrane reviews when the background studies are not of good qualities. Some physiological points you know as well as I do, just to remind you that when you use colloids, you always will rise the oncotic pressure, and unless you got a significant increase in the differences in the hydrostatic pressure, the colloid use will result in decrease in tissue perfusion. Another important thing to keep in mind is that our organs and our tissues are very well protected. They have their own local regulatory process for ensuring an adequate fluid balance, and this involves, of course, the lymphatic flows. And as long as hydrostatic pressure in the tissue doesn't go over a certain cutoff value, the lymphatic flow will allow maintaining the balance of water within that particular tissue. So, in theory, I have put the various arguments in green in favor of and in red against the use of either crystalloids or colloids. And it's obvious from that slide that there is, in theory, much more green in the crystalloid sides than in the colloid sides, suggesting that the theoretical considerations favor the use of crystalloids. And let's go a little bit further and deeper into clinical evidence. So this might be the next recommendation from the Surviving Sepsis Campaign guidelines according to the use of fluid in patients with severe sepsis or septic shock. Again, there are the final recommendations are not yet established, and there will be likely these will be likely fine-tuning in the next couple of weeks. But it's likely that this will end up with a very strong recommendation of using crystalloids as a first-line agent when resuscitating patients with severe sepsis and septic shock. There also will be likely a suggestion of adding albumin on top of crystalloids whenever needed. And finally, a strong recommendation against the use of starch solution. So why this? First question to answer is, are colloids superior to crystalloids to achieve the so-called hemodynamic targets in patients with severe sepsis or septic shock? So what the studies showed, the SAFE trial from the ANZI group comparing albumin to isotonic saline indeed showed that with albumin, the likelihood of increasing and reaching the CVP target was higher with albumin than with saline solution, and also albumin allows to reach this target earlier than with the crystalloid solution. This was also true in the VISAP trial from the German group in 500 patients with septic shock, where patients who were randomized to the second-generation starch solution actually reach the target of CVP much earlier than patients who did receive the Ringer's lactate solution. Regarding mean blood pressure, there was no differences in the time or the value of mean blood pressure reached with albumin compared to saline solution in the SAFE trial, and there were no differences for that hemodynamic target for starch solutions or Ringer's lactate in the German trial. Regarding the central venous oxygen saturation, in the German study, although there was a trend toward an earlier achievement of that target with the starch solution, the difference was not statistically different. This is a very interesting work. In the left-hand side, you have experimental data with showing the lung of animals challenged, the sham animals or animals challenged with Ringer lactate, with albumin in a dose-dependent manner, albumin 5% or albumin 25%. And one can see that compared to Ringer lactates, albumin dose-dependently reduces lung damage in these animals. On the right-hand side graph showed the Greg Martin data on a randomized trial of albumin added in patients with albumin plus diuretic in patients with acute lung injury, and one can see how in the dotted line albumin was associated with a greater PF ratio compared to the placebo arm. This occurred very early in the time course of a study and lasted for at least the first 72 hours. In this Wills trial, which was conducted in a very particular form of septic shock, it was children with DING toxic shock, and they were comparing dextran starch solutions and Ringer's lactate, and again they didn't find any evidence that the starch solution resulted in an earlier stabilization of the hemodynamic status of these kids. This double-blind, multi-center, randomized control trial that was conducted in France and is in press in critical care, 200 patients were randomized to receive either a low molecular weight starch solution or isotonic saline. And in that particular trial, one can see that the amount of fluid needed to achieve the hemodynamic status, stable hemodynamic status, was lower with the starch solution compared to the crystalloid solution, and this was not surprising. But the time to achieve the hemodynamic status, time to initial HDS, was not significantly different between the two treatment arms. And the number of patients who required intravenous vasopressor was also not significantly different. So, suggesting that in these adults with septic shock, as in the kids with dengue toxic shock, the starch solution was not able to provide better hemodynamic stability than the crystalloid solution. You may know about the Scandinavian trial that was presented by Anders Perner in March in Brussels and is now in press in the New England Journal of Medicine. They have randomized 800 patients with septic shock to receive either a low molecular weight starch solution or Ringer's acetate. And one can see here again the so-called hemodynamic targets to be achieved in septic shock patients, CVP, SCVO2, and lactate levels over time, the first 12 hours and then from 12 to 24 hours from randomization. And one can see that the CVP, SCVO2, or lactate levels were different between the two treatment arms over time. So further highlighting that in properly controlled clinical trials, there was no evidence for a superiority of starch solution in getting a stable hemodynamic status. Regarding the effects of colloids versus crystalloids on survival, I think this should be seen separately for synthetic colloids and albumin. So let's just have a look at the effects of synthetic colloids versus crystalloids on survival in patients with severe sepsis or septic shock. Again, we already had the VISAP trial published in 2008 that showed non-significant increase in the risk of death with starch solutions compared to Ringer's lactate. And the 28-day mortality was not significantly different, but at 90 days, so there was a trend toward a significant increase in the risk of death with the starch solution compared to the Ringer's lactate. Up to now, the updated Cochrane review on starch solution compared to crystalloids has shown by the red smiley just a pooled estimate fall on the neutrality line, suggesting that with a p-value of 0.8, suggesting that there is no difference in mortality comparing crystalloid to colloids. The Scandinavian trial has followed a fast-track peer review process at New England Journal of Medicine because of these findings, where one can see that the survival curves of patients receiving the Ringer's acetate was above the survival curve of patients receiving the starch solution, and the two curves separated somewhere around 28 days. And basically at 28 days, there was no significant differences between the two groups. However, at 90 days, there was a significant increase in mortality in patients receiving the starch solution. So I think that there are two very large completed trials, actually, the CHEST from Enzig that have enrolled 7,000 critical patients of Foliven compared to isotonic saline, and the final data will be available in end of June, very early July this year. And the Crystal study, which have included 3,000 patients, and the data of which will be presented in Paris on June 6th or June 7th during the presentation of a Surviving Sepsis Campaign Guidelines recommendation. So we'll see from these two very large trials, I guess, a definite answer regarding the benefit to risk ratio of synthetic colloids versus crystalloids to resuscitate critical patients, and in particular septic shock patients. Regarding the effects of albumin versus crystalloids on survival, we had the SAFE trial that, as you know, didn't show any difference in survival between the two fluid solutions, and this, regardless of time point, they were looking at mortality, 28-day ICU discharge or hospital discharge. There was also no significant difference on length of stay in the ICU or in the hospital, no significant difference in the time on mechanical ventilation, and no significant differences in the time on renal replacement therapy. As you know, these patients were mildly sick, with almost half of patients not having organ dysfunction, and over time one can see that about 1/3 of patients developed further or developed additional organ dysfunction. When they looked at different subgroups, and these subgroups were a priori defined, the randomization was stratified on that type of category of patients, they suggested that the third plot that in patients with severe sepsis, there might be some advantage to albumin compared to the saline solution. They looked also at the subgroup of patients and the response to albumin according to baseline albumin levels, and they demonstrated that regardless of baseline albumin levels, the use of albumin was not associated with any favorable effect compared to saline solution. This group then conducted a systematic review and meta-analysis of all randomized controlled trial of albumin solution in patients with severe sepsis or septic shock. They ended up with 17 trials. And as one can see on that slide, they withdrew all the studies from Joachim Ball, given the controversy surrounding the papers from that group of patients, as you may know. So they decided to withdraw these papers from the analysis, and then they ended up with a significant reduction in the relative risk of death in patients receiving albumin compared to a crystalloid solution. This is a yet unpublished multi-center randomized controlled trial that was conducted in France under the supervision by Jean-Paul Mirat at Cochat Hospital in Paris. And in that particular trial, they randomized patients to receive albumin or a placebo on top of the standard resuscitation of septic shock patients. In that particular study, it is important to highlight the fact that they were investigating albumin as an antioxidant molecule and not as a fluid solution, as to fluid resuscitate the patients. They didn't find any significant difference in survival between the two treatment arms, but the relative mortality reduction favors albumin. And coming soon also, and again, these results will be available at the end of June. The Albios trial was conducted in Italy, and they randomized about close to 2,000 patients with severe sepsis or septic shock. The randomization was stratified according to the time points the patients were seen: early phase of septic shock within the first 12 hours, or late phase of septic shock after 24 hours. These data were partly preliminary data were discussed and presented in Milan by Luciano Gattinoni, suggesting a survival benefit in albumin-treated patients, in the sickest patients, those with shock, and no benefit in the less sick patients, but these data have to be confirmed in the final analysis that will be known by early July this year. Do colloids have more side effects than crystalloids? We know from Frederick Schogen prospective cohort study that the use of starches or of albumin in cohort studies has been repeatedly associated with increased mortality, with increased risk of death. One argument against the use of crystalloids was that crystalloids may be associated with more lung edema. Also, a very early meta-analysis by Deborah Cook and her group demonstrated that there was no evidence in the literature supporting the increased risk of pulmonary edema with crystalloids compared to colloids. Regarding the acute kidney injury, which is the main side effect people were worrying about the use of starch solution, again, there is a direct inverse relationship between the oncotic pressure and glomerular filtration rate in the kidney. So in the SAFE study using albumin, again, there was no evidence for adverse events at the kidney level. With starch solution, the VISAP trial showed an increased risk of acute kidney injury with more patients requiring renal replacement therapy. But as you know, the criticism about that trial was that the cumulative dose of starch solution used was very high, far beyond the toxic dose that was known for that solution. In the GIDE trial, which is in press in critical care, they use both the Akin staging or the Riffle scoring system, and they didn't find evidence for differences in the number of patients with acute kidney injury according to the fluid solution the patient were assigned to. However, in the Scandinavian trial, there was a significant increase again, as shown in the German study, increase in risk in requirement of renal replacement therapy, and also a lower or fewer days alive and free of renal replacement therapy. Regarding bleeding effects, and this, the starch solution may indeed affect the coagulation system, and in the Scandinavian trial there was indeed an increased risk of bleeding with starch solution compared with Ringer's acetate. This was not found in the French trial. So to conclude, my dear friends, is with the data available so far, crystalloids should be the first-line therapy for fluid management in patients with severe sepsis or septic shock. That synthetic colloids and particularly starch solution should not be used, awaiting for data from the CHEST and CRYSTAL trials. And albumin may be given in addition to crystalloids whenever additional fluid is needed, and this will likely be confirmed by Luciano Gattinelli trial. Thank you very much.